thank you to Dr. Kevin Smith, who's doing the presentation. You saved my bacon, Dr. Smith, because we were going to have our presentation, and I was approached, and I'm an adult psychiatrist in Dawson Creek, but I said, why don't we get someone who really knows what they're talking about if we're going to do this? And we're very grateful to you for stepping up and coming to teach us some new things. I think it's a very important topic, and I mean the amount of drug side effects and things that we see in our adult population are really significant with psychotropic drugs, and when one gets to psychogeriatrics, I think it's almost an exponential curve, and one certainly sees a lot of people having mental health difficulties, but also trouble with their drugs. And certainly my experience that we I see different side effects in geriatric clients than in adults. So it's really nice to have an expert in the field, and we appreciate your time for joining us. Just reading on the event poster, by the end of the presentation, participants should be able to recognize the uniqueness of older adult depression, discuss treatment options for depression, and define an approach to deprescribing. And I think for me, that's a highlight of the talk here. I think deprescribing is big, and it needs to get even bigger. So really looking forward to the talk. Dr. Smith, welcome, and thank you again.
Thank you very much. Well, it's my pleasure to join. This is a topic that I'm rather passionate about. I treat, oh gosh, probably 80% of my patients have either a major depression or some kind of a mood disorder. I have a bit of a specialty in electroconvulsive therapy, and so I'm used to seeing fairly treatment refractory patients. To give you a little bit of my background, I trained in the US and have been in British Columbia since 2012. I'm currently on faculty at UBC and am the division head for geriatric psychiatry at Providence here in Vancouver. I'm going to share my screen. Hopefully this all works well. It did earlier. I'm going to assume that you all can see that. And then I also, as I recall, I think that everybody has my PowerPoint file. Is that correct, Raina? Am I making that up? Or Sydney, do you guys know?
We have it. I don't know that it was shared, but we can pass it on.
Okay. Yeah, you're more than welcome to share it. I have a lot of slides, and you know, this topic could be a 2-hour topic easily on its own, and so we don't have 2 hours. So I'm going to go through some of these slides rather quickly. So let's get going without further ado. I have no conflicts to declare at all. There are some resources that are available related to geriatric depression, some of which are specific. Others, like the American Psychiatric Association practice guidelines for treating depression, are not specific for older adults. But there are specific guidelines in the special population section for the CANMAT guidelines here. You know, I kind of asked the question, is depression different as we age? The fact that we're here tonight or this afternoon means that I think it is. If we look at the incidence of a major depressive episode or even depression as a symptom, and we'll talk about the distinction in just a little bit, it's very common. And depending on where researchers would go to try to find out how common it is, it varies. If you go to a nursing home, for example, the incidence of depressed mood is very, very high. If you go to knocking on doors in the community, it's not as high. But as we age, it is fairly common. There's a fair amount of just kind of treatment, either ambivalence or nihilism that can occur with depression when it's being assessed by us. We'll talk about medical illness, and I'm sure that I'm preaching to a choir who already recognizes that comorbid medical illness plays an important role in all psychiatric illness in the elderly, but especially when it comes to mood disorders. Suicide risk is quite high in older adults. And again, we're going to talk about that just a little bit. There is evidence that even with effective treatment, with good, solid, aggressive treatment of a major depressive episode, there is frequently incomplete remission of symptoms that try as we may, as hard as we may, sometimes patients just don't get all the way better. I put this up because I believe this is true with all of my heart. Major depressive episodes are important to not miss, and people will die from them if we don't pay attention and treat aggressively. And I don't mean just from suicide. When people are depressed, underlying medical illnesses get worse, either because patients choose not to go seek care, or they don't take their medications, or just the impact of the depression affects underlying physiology. But just the severe neurovegetative symptoms. And I'm going to present a case briefly about a woman, and you'll see why it became so relevant and so important not to miss. So let's talk about Blanche. This is a real case, so obviously the names have been changed. This is a 76-year-old woman who had a previous history of major depression, had been treated for quite a while with Mercazapine, and was overall quite successful in remaining euthymic or symptom-free. She lived independently. She was divorced. Her daughter lived nearby and was actively involved. But really, the patient was quite a go-getter. She enjoyed her Zumba class and was quite an active, dynamic person. They came to see me because over the previous 6 months or so, she was starting to show a decline in her mood. A reasonable medication list, some digoxin, Mercazapine that she had been on, metoprolol, ranitidine, and alendronate. And she didn't really have much of a family history playing a role. Her psych history was significant for 2 previous hospitalizations, had never been suicidal, had never had a suicide attempt. And she had been on medications for more than 40 years. And as you might imagine, she'd had just about every class of medications, but had finally settled on the Mercazapine and hadn't really taken part in psychotherapy. Her vital signs were normal. As you can see, she's not a large woman, 120 pounds, which gives her a BMI of 17. So she's really kind of on that verge of almost being a little bit underweight, but she's always been at that weight. Again, she's very healthy, and ordinarily that wasn't a problem. Her mental status exam was really consistent with somebody who was depressed. Cognitively, mostly intact, whatever that means. Her 2-item recall was 2 out of 3, or her 3-item recall was 2 out of 3. Her attention and concentration were normal. She was not delirious, and she did have insight into her depression. Her medical workup was really quite negative. We're going to talk a little bit about depression. There are things that I think are different in geriatric depression for why it either precipitates an episode or for why one starts brand new. And if you look at the first 4, it's all about loss. Things change as we get older. We lose our health, we lose our partners, we lose our family, we might lose our home. And so loss after loss after loss for many people starts to precipitate a sense of sadness and desperation at times. And those kinds of things set the stage for the development of an underlying mood disorder. Some people have a recurrence of their mood disorder. If somebody has a major depression like Blanche did, when she reached the age of 65, her history didn't go away. And so people can still have episodes of their usual mood disorder well into their aging years. The first question that's on my mind when I'm seeing people for a mood disorder is the diagnosis correct? I mean, the symptom is depression, but is it really a mood disorder, like a major depression or an adjustment disorder? There was a study actually in Oregon, where I came from, looking at patients who were referred to an inpatient consult service, where the referring diagnosis was essentially rule out depression. And the study showed that of patients who are in the hospital with a depression diagnosis, a large percentage of them are actually delirious. They don't have an underlying depression. And a take home from the study was that if somebody is crying, if they're tearful, that should be like a big red flag that they're actually delirious on an inpatient setting versus having a major depression or some kind of a mood disorder. Medical illness frequently can either contribute to mood symptoms or can be misdiagnosed as a mood disorder. Many are familiar with checking thyroid studies and checking your urinalysis and just making sure that medically people are stable. A big focus, it sounds like, of your programs has been looking at deprescribing and oftentimes medication side effects or just the cumulative effect of medications can look like a mood disorder. And we'll talk about that in a little bit. The usual board exam question for malignancy is pancreatic cancer and depression. But any kind of a cancer can have systemic effects. Any kind of a brand new onset of mood disorder symptoms really deserves a full workup, and that may include neuroimaging to rule out something going on in the head. Psychotic symptoms can be subtle, but if somebody has severe underlying depression, making sure that you're not missing psychotic symptoms is important. There's a syndrome called apathy, and apathy is kind of the lack of interest or the lack of drive for things. And it can be a symptom of a mood disorder, but it can also be a symptom of underlying neurologic conditions. So things like Parkinson's disease or strokes, multiple sclerosis, Alzheimer's can all cause apathy. And you can pump people full of as much antidepressant as you want to, and it's probably not going to respond because it's not a major depression. It's not a mood disorder. It's really a symptom of an underlying neurologic illness. Anxiety sometimes can actually look like depression. And I have a lot of, I use depression, and many people use depression kind of liberally without really talking about what we specifically mean. Depression can be a symptom, and oftentimes is a symptom. It's actually not a disorder. It's not a diagnosis, so to speak. It's kind of like nausea or chest pain. We can say we're treating this patient for chest pain, but really what is it that you're treating? Like, what's the underlying condition that you're treating? And so as a psychiatrist, I'm always trying to think of what is the actual diagnosis aside from just the symptom, though we do commonly use the two synonymously. And I think important for us all to remember is that just because someone has sadness, they have depression, it doesn't mean that it requires a medication. And I think oftentimes we get caught, and I do as well, we get caught in the mindset that here's a symptom, here's a pill. But it doesn't have to be like that. And many times it shouldn't be like that. Patients are oftentimes encountering things that complicates their treatment or their depression, and medication compliance is one of those things. Lots of patients take medications as they want, not as they're prescribed, for a whole host of reasons. And I think it's important in doing geriatric work to clarify what are you taking, what aren't you taking. When patients have blister packs, I always make them bring in the blister pack. When they have pill bottles, I always have them bring in the pill bottles to look to see how many pills are in it. What was the fill date? And does it look like it's roughly close, or is it a subscription for sertraline from August of 2020, and there's still 15 pills in it, and it's clear that they haven't really been taking the medication. When people are cognitively impaired, they may cheat their medicines. If people are not, and then spit them out. If patients aren't really invested in their treatment, they may say that they're taking the medicine, but then end up hiding them. So compliance can be an issue. The cost of medications is also important. And sometimes it isn't just the medicine itself, which may not be very expensive, but it's the dispensing fees. And if somebody is on 8 or 10 medications and they end up having a dispensing fee with each of those, it can be quite a costly venture. Some of the newer antidepressants can be really expensive. I have a patient, a younger patient, that I'm putting on one of the new, actually the brand is the most brand new antidepressant, and it's about $250 a month. Which is really quite costly for many of our patients. We are also not to blame when it comes to patients getting better or not getting better. And sometimes we just need to take the time to recognize that somebody is actually depressed. I have lots of respect for our family medicine colleagues because they are just responsible for so much. And sometimes depression ends up taking is lower on the hierarchy of needs, either because there just isn't time to talk about it, or the patient is kind of manipulating the time or taking the time to focus on stuff that actually is part of the bigger depression picture, but doesn't really get talked about as being depression. I always put in here in my talks the notion of you'd be depressed too if, and I try to push against that, because we would never say, well, you would have diabetes too if, or you would have chest pain too if. That it's really something that we have to pay attention to and not just try to minimize somehow. Depression, major depression is diagnosed through the DSM-5 criteria, and I'll show those in just a moment. One thing that is a little bit different in geriatric depression is really a somatization that occurs. People tend to have a lot more somatic complaints than in younger adults. And I think that's an important thing to notice. I'm not going to spend a lot of time on this, but there's my pointer. So there's the SIGECAPS, SIGECAPS, which just kind of encompasses the 7 overall criteria of, the 8 criteria of a major depressive episode, and you look for the presence of at least 5 of those to be able to diagnose a major depressive episode. So this is my attempt at humor. And bowels in depressed people seem to be the most important organ in the body. Somatization is important to pay attention to. In younger people, we would just commonly say they're symptoms of depression, but in the elderly, loss of appetite, weight loss, fatigue, we really would be starting to think about physical illness, and we should. Some studies have looked at somatization disorders in the elderly, and commonly major depression is a huge component with the overall symptom cluster that people have. The study that I referenced earlier showed that people were more likely to be called difficult patients before they would be called depressed. So somebody who has an ongoing physical symptom, and every time they come into the office, it's about the symptom, and at times it frankly becomes a bit annoying, but that person then is more likely to be called difficult than to kind of step back and say, what all is going on with this person, and then realizing that it actually is more like a depression episode. We psychiatrists have not been helpful in approaching somatic symptoms that come to us because we frequently would put it back on our medical colleagues and say, yes, but have you ruled out this and this and this and this? And so oftentimes what happens is that patients spend a lot of time getting tested and evaluated and so on, and that leads really to an overutilization unnecessarily and to a delay in the treatment of their depression. It also exposes patients to untoward side effects, either of tests and treatment, tests themselves, but also potentially to treatments that aren't necessary. So the way that I tend to approach somatization, and the way that I recommend for people, is that if you're seeing somebody who has a particular symptom or kind of a cluster of symptoms, and the symptoms don't really match kind of the usual physiology or the usual anatomy, and if the usual treatments tend to not respond, then you should, not necessarily give up on the pursuit of what might be going on medically, but in parallel, starting to have the question of, could this really be a depression syndrome rather than a physical syndrome of some kind? And again, I will especially say that's true if it comes to bowels, and if it comes for some pain illnesses. I saw or had a telephone appointment with a patient today who has a lot of pelvic pain, and she's had ultrasounds and evaluations by her gynecologist, and ultimately it seems that it's really related to her depression and anxiety. And so the approach is becoming less about what may be going on in her pelvis and more now about what's going on with her depression. So what are the treatment options? Well, this is an area that I'm always mindful of. So patients, older adults, do require, for the most part, adult serum levels. Oftentimes they don't require as much medicine to get there, or it takes a little bit longer to get to that adult level, just because of the concern about side effects or tolerability. Almost all of our older adult patients do take other medications, and so the risk of drug-drug interactions has to be in mind. The last bullet point, I think, is one of the most important things that I talk about with my patients, with their family. I talk about it with the medical students and residents and other students that I have with me. Every psychotropic that we use, whether it's an antidepressant, an antipsychotic, an anti-anxiety medicine, was not designed, sorry. Whoops. I tried to silence and I went crazy. One moment. Where was I? Sorry. Okay. Every medication was developed in younger people, not 85-year-olds who are on 7 other medications. The only exception to that are the cholinesterase inhibitors for treating Alzheimer's disease. So if you were to ask me what is the effective dose of sertraline in a 90-year-old, I don't know. What is the effective dose of lorazepam in a 75-year-old? I don't know. We have really very, very limited research base to be able to tell us what the dosing should be. And so we kind of guess. We know roughly where to start, and then we just kind of work up from there based on response, tolerability, side effects. With all of our medications and with all of our patients and all of the medications that they're taking, the side effects really do become cumulative. And this is true especially for anticholinergic side effects. Larry Tooney did some interesting research looking at anticholinergic burden in patients, drawing serum and then doing an assay looking at, this is a difficult word to say, anticholinergenicity of that serum. And the more medications that patients were on, the more anticholinergic their blood was, which means the more anticholinergic their brain is. And that's what causes a lot of the cognitive side effects. And medications that we wouldn't ordinarily think of as being anticholinergic, like furosemide or cimetidine, digoxin, actually are mildly anticholinergic, and it was all compared to atropine as being the standard. So if we add medications that are anticholinergic, psychotropics that are anticholinergic, along with other medications that people are taking, we actually could tip the scale and make somebody more confused than they would have been. So a medication like paroxetine, which actually is mildly anticholinergic, or nortriptyline, which is also mildly anticholinergic, if we throw that on top of other medications, we could actually make somebody much more so. Same thing is true of hypotension. If people are on blood pressure medicines and then we add other medications on top of it. If people are at baseline hypertensive and we add a medication like venlafaxine and start pushing the dose, lower doses not so much, but if we start getting above 225 milligrams of venlafaxine a day, theoretically we could be pushing their blood pressure a little bit. There's a new antidepressant called Levomalnasapran, which is an SNRI, small s, big norepinephrine reuptake inhibitor, and it actually can cause an elevated blood pressure even in lower doses. Electrolyte abnormalities, bleeding abnormalities. If somebody is on warfarin, we would need to be mindful if we're going to put them onto an SSRI as well. A little bit of debate about the actual interaction, but it's at least reasonable to be mindful of. If somebody is baseline kind of wobbly when they're walking, there's ample data to support just about every psychotropic increasing a fall risk. All antidepressants, all psychotropics really can potentially cause constipation or diarrhea, sleepiness or sedation or wakefulness. So just kind of thinking about the overall side effect burden of medications is important. Which antidepressant somebody might choose really, in some ways, doesn't matter because they're all equal. There's no antidepressant that is better than another. The thing that sets them apart is really their side effect profile or potentially their drug-drug interactions. And sometimes we want to take advantage of that. So Mercazapine oftentimes is a bit sedating for people. And so using a medication that's sedating for somebody who can't sleep makes sense. If somebody is sleeping way too much, using a Mercazapine may not be a reasonable choice. I'm going to just kind of move through these fairly quickly. MAOIs we don't really use anymore. Unless you're a psychiatrist, you're probably never going to prescribe one brand new. Maybe once every year or two, I'll start one of the traditional MAOIs, but they're really not used too often. I do think that tricyclics play an important role for many patients, although avoiding amitriptyline, doxepin, and imipramine because they are the most anticholinergic. SSRIs are pretty much the first line treatment, and I think that's pretty reasonable. Mercazapine, I have a little bit of a soapbox about Mercazapine and weight gain. It has this huge clinical lore about it causing weight gain. I can promise you that Mercazapine does not have 100% incidence of weight gain in any age group, and unfortunately, when we might want it to in the elderly, it won't. And so you can give it a try, but if you put somebody on Mercazapine just hoping that they're going to gain weight, you likely will be quite disappointed. Trazodone we tend to not use as much for depression, though it wouldn't be wrong to do so. And if somebody's taking 100, 150, 200 milligrams of trazodone to help them sleep, one, it's probably not helping them sleep. That's what you're using it for, and it may actually be helping more with underlying depression if it seems like it's helping them sleep. The main limitations would either be sedation from it or potentially hypotension. Vortioxetine, again in the elderly, nausea, and this was specific older adult data, looks like nausea is the biggest side effect to worry about. Vilazodone, limited data. Levomalnasapran is, I think, the newest antidepressant available, and again, very limited older adult data. Antipsychotics we use if somebody has a severe depression, sometimes augmenting the antidepressant. There's data for risperidone and aripiprazole in the elderly. If somebody is frankly psychotic as part of their major depression, they really do need to have an antipsychotic on board. A big issue in the elderly is tardive dyskinesia, which is kind of an uncontrollable movement in any kind of voluntary muscle that can develop. Risk factors are elderly women who have a mood disorder. They're kind of the highest risk. Diabetes is a risk factor, prolonged exposure, presence of underlying extrapyramidal symptoms. The atypical antipsychotics, the second generation antipsychotics, are much lower risk than the first generation, but I have seen tardive dyskinesia with just about every atypical antipsychotic. So it's important to be mindful that it can happen. Benzodiazepines, again, we love them and hate them. They are a double-edged sword. Sometimes they play an important role. I think that we should always have a goal of minimum dosing, minimum length of time, but sometimes they are a necessary evil. Antihistamines such as diphenhydramine, for example, to help with sleep or anxiety, really should not play much of a role. Psychotherapy is a benefit, especially cognitive behavioral therapy. One of the important things, though, is that people have to be cognitively intact to take part in psychotherapy. It requires that you remember that you have a psychotherapist, for example, or that you remember kind of what was talked about. And a lot of psychotherapy takes part between the sessions, and people have to be kind of pensive and psychologically minded. For people who are cognitively impaired, though, other types of therapy like reminiscence therapy, art therapy, pet therapy can actually play important roles as well. I'm not going to talk about that too much. So back to Blanche. So with Blanche, she wasn't doing well. We started the plan of working on either transitioning her to sertraline or doing some augmentation with a second antidepressant. So I lowered the Mercazapine and started her on a low dose of sertraline. She developed some crazy dreams, which probably was because of the serotonergic effect of both medications. So we stopped it and put her onto a little bit of lithium. Over the course of the next month, her weight went from 120 pounds down to 108, which is 10% of her body weight. And I always say, if I lose 10% of my body weight, I'm going to give you 2 thumbs up because I'll be pretty excited. In an elderly person who's losing weight because of depression, 2 thumbs down. That's where things start to get serious and things start to get quite dangerous. We talked about the issue of hospitalization. The patient didn't want it. The daughter didn't want it. Lithium level was low, so we bumped the lithium dose a little bit. Follow-up, she's continuing to lose weight, even more psychomotor retardation, and really is not very verbal. She's not actively suicidal. The patient and her daughter really did not want her in the hospital. And so now we have kind of this emergent situation with a woman who effectively is dying from her depression. She's wasting away very, very quickly. And so that's when we started to talk about electroconvulsive therapy. I think we cannot talk about depression in the elderly without talking about ECT. Again, I'm not going to go into tons of details, but I do think it's important to know that ECT is done. It's done a lot. It is very, very effective in this age group. And I always say, if you are an elderly woman with a psychotic depression, come see me. Because ECT is like the treatment of choice for you. And Blanche was very quickly showing that to be true. ECT has been done clinically since the 1940s, and overall the premise of it is really much the same. Under anesthesia and under muscle relaxation, we use electricity passed across the scalp into the brain to induce a seizure. And it's that seizure that ultimately proves to be effective. It's not the anesthesia that is effective. There are very few contraindications for somebody to undergo ECT. I always say the only absolute contraindication is lack of informed consent. We can't just give somebody ECT without some kind of a process of other people being aware, whether it's the patient, family, a surrogate decision maker, etc. There are other neurostimulation modalities, but most of them are either still research or there's not a lot of geriatric data that we have. So Blanche and her daughter decided to go through with ECT. This is the first time she had ever had it, actually. We stopped the lithium, and she had 11 right unilateral ECT treatments. So a stimulus at basically the top of her head and at the tip of her temporal lobe on the right side. She had 11 of those, and we did them twice a week, usually like Monday, Wednesday, Monday, Thursday, something like that. It took a few treatments, but then she started to eat a little bit better and was a little bit more conversant. And after the 8th treatment, the patient started to feel better, which is often the case. Others notice it first. And by the 11th treatment or so, she was really feeling pretty normal. So in the course of about 6 weeks or so, she went from being really very, very psychiatrically unwell to being basically her normal self again. We kept her on the Mercazapine, did a little bit of maintenance ECT, and I got the cutest card I've ever received from somebody. And she really seriously signed it, "Shop till you drop," which I thought was, actually, when I got that card, I thought maybe we overshot the mark and something was a little bit wrong. But ultimately, she was just back to her normal, vibrant self, going back to Zumba and doing quite well. Whenever we're treating depression, I think that it's important that we try to have some kind of objective measures. And I've become much, much more a fan of these than originally. And I think part of that was where I trained and how I trained, but using PHQ-9s, where do I have this? Geriatric Depression Scale. If somebody is demented, there's a Cornell scale for depression and dementia. The Beck Depression Inventory. These are all just measures that either somebody else observes and does the scoring, or the patient scores it themselves, so that we can kind of track over time, is our treatment effective? Are they starting to show a relapse of symptoms, that kind of thing? And we do blood pressures all the time, and it's easy enough to do these tests as well. Oftentimes patients can do some of them, like the Geriatric Depression Scale or the Beck Depression Inventory, the PHQ-9, when they're sitting in the waiting room. So they're easy enough to do. Recurrence is a reality, unfortunately, for our patients. And one study showed that it can be up to about 30% over the course of 4 years, which, and again, this is talking about a major depressive episode, which unfortunately is too recurrent. Reasons that patients recur is sometimes they're actually not able to go into remission for whatever reason. Sometimes we think, well, they're a little better, so that's going to be good enough. Sometimes patients, unfortunately, have side effects from the medications and they end up just stopping them. And sometimes we, as prescribers, as physicians, don't have good familiarity with where we should be going with the doses of medicines, and we just don't either push the dose high enough or push in a way to help people get completely well. And again, the importance of remission, of really being symptom-free, no more symptoms of depression, is that it helps to lower the risk of relapse. Residual symptoms do have morbidity. I have a patient that responded beautifully to ECT, but when he's most depressed, his cardiac output, his cardiac function really becomes very, very miserable. And there's always a debate about whether he's actually fit for ECT. And the argument is, if we don't do ECT, he's going to die. So, either recurrence of symptoms or residual symptoms can have significant long-lasting effects. There's very little data to support how long somebody should stay on their antidepressants. And, I have patients who have been on the same antidepressant for 30 years, 40 years, Blanche, for example. And they've really not had any recurrence. you know, I like to try to keep things simple. And so we start having discussions about lowering the dose of medications. And it isn't uncommon for making change, when we make changes with medications, that people actually start to have a recurrence of symptoms. And I can't explain why it is, especially when they've been symptom-free for so long. When it comes to, and we're going to talk about deprescribing here in just a short time, when it comes to deciding, you know, how long should somebody be on medications, I think ultimately it comes down to how sick were they when they were first put on medications in the first place. So somebody like Blanche is going to have to be on antidepressants for the rest of her life, because the risk of her not being on them, the risk of her having a relapse is too great. The same thing with my gentleman who has the bad cardiac output when he's depressed. He's going to be on his sertraline is what he takes. He's going to be on that medication for the rest of his life, because the risk of not being on it is far too great. Psychiatric illness is recurrent, and as I mentioned, there's no age limit for who gets it. I think it's important that we all know that, and I think we all know, that medications that used to be appropriate might not be anymore. For people who are living in long-term care, it may be that the structure, the support, kind of the non-pharmacologic aspects of treating depression are just as important and just as helpful as any medication. I'm quite happy about the movement for deprescribing, because there's kind of a culture of sameness. If it's not broken, let's don't fix it. And so people will be on medications, you know, that they really don't need to be on. And in some cases, they really never needed to be on, but they're doing okay, so let's not change it. And I think that's an important aspect of deprescribing. At the same time, when I was practicing in the US, this was happening in nursing homes, in large part because the federal government was quite heavy-handed with how they were overseeing long-term care. It was that there was a push that if somebody was on a psychotropic, they really needed to just come off of it. And there oftentimes wasn't a lot of thought that went into it. And I think that to do it in that manner is really unethical. I think it's not a good standard of care. And I think it also kind of plays to the bias against mental illness as we age. You know, we would never say, oh, this person is on, you know, these heart medications, let's just take them off of them. And I think that it's unreasonable that automatically we would just say if somebody's on sertraline, we need to just get them off of it. Now, if you all are familiar with the Beers criteria, and those are medications that are essentially deemed inappropriate in the elderly, and I have a little bit of a love-hate relationship with the Beers criteria, but I think there's a lot of merit to the premise that as we age, there are medications that patients really should not be on, if at all possible. And I think that's where a lot of the notion of deprescribing has started to come. Reassessment of somebody's psychiatric status, reassessment of their psychotropics, and removing medications that aren't necessarily, I think, is very clinically indicated. Sometimes somebody may be on a medication that they're not tolerating very well, and just switching to a different class or switching to a different one within a class may actually be more tolerable. Sometimes people are on a little bit of one medication and a little bit of another medication, and if really we maximized one and got them off of the other, that may be a way of trying to simplify their medication regimen. But I think the most important thing is to make sure that we have good communication with the patient and with their family, because a lot of patients are very nervous about changes with their psychotropics, and families may be very nervous about changes with medications because they've lived it. And you know, oftentimes when I'm asked to see a patient, we start talking about their medication regimen and changes to make, 45 minutes into my knowing them. And if they've, had long experience of really severe illness, and here comes Dr. Smith, who wants to just make changes with medications, it makes them anxious very quickly. There is a website, please don't hurry up and scribble this. You may already have it, but we'll give the file to everybody. Just for some notions about making changes and potentially deprescribing antidepressant medications. The other thing, let me just say it here because I don't recall if there's a slide coming up. There are times where patients come to me on medications that they've been on for 40 years. Old medications, old antidepressants that really aren't used anymore, especially the tricyclic antidepressants. And I had one week where I had two women. One was on Doxepin, and the other was on an old antidepressant called Amoxapine, which gets metabolized into loxapine and another medicine. And I was young in my career, and I'm thinking, oh, these are horrible medications in geriatrics. We need to get you on something new and modern. And so we went through a thoughtful process, I thought, of taking them down and off of the Doxepin, down and off of the Amoxapine, and onto whatever treatment of choice. And symptoms came back, they didn't do well, tried them on something else, not doing well, tried them on something else, and ultimately we ended back up on Doxepin and Amoxapine. And so sometimes, even though I think that I'm doing my patients well by trying to get them onto better medicines, ultimately it may not be better for them. And so anytime somebody's coming and I'm thinking about what I might want to do with their medication, those two cases always come into my mind and give me pause. For every patient that I ever see brand new, I'm always, I oftentimes will take a red pen on their MAR or on their blister pack and just make a mark for how many medications directly affect their brain. And that's true whether it's a psychotropic, whether it's gabapentin, whether it's codeine or hydromorphone, whatever it is, they get a red mark. And I pay attention to how many red marks there are because medications that are centrally acting, the side effects of all of those are going to be cumulative. And so I'm always mindful of that. Does the patient's history, does their psychiatric history support ongoing use of the antidepressant or their psychotropic regimen? Sometimes patients, I've seen many patients who a spouse dies and they go to their family doctor or they go to see somebody, no offense to family doctors, and at the death of a spouse, a week later, they're put onto an antidepressant medication. I always worry about that because that kind of goes to the symptom of not every sadness needs a medicine. And so there are times where, 2 years later, I was put on it when my husband died or when my wife died, that maybe they just don't need that antidepressant anymore. So we talk about a strategy for deciding if they still need it. When was the patient last symptomatic? And again, with some of our patients, it's been 2 decades ago. Even in those cases, I do think that it's reasonable to look at, trying to lower or potentially take away doses of medications. Will the person be worse off without the psychotropics? When I see patients that are on 4 or 5 or 6 different psychotropics and they're still symptomatic, you have to wonder, what if we just cleaned house and kind of started all over to see what we're actually, what the diagnosis might be? And then if we do decide that we're going to taper, is there a strategy in place or is there a support in place to monitor for if there is recurrence? And how are we going to be tracking that? Let's talk briefly about suicide. Again, if we look at populations that are most at risk, older adults are the highest group. And oftentimes the notion of suicide focuses on the issue of loss. What is one's purpose anymore? who's around. One day is just like the next. Physical health problems. There are a lot of things that are kind of set the stage for the progressive development of suicidal ideation and eventually an attempted suicide. Some suicide myths that you all can kind of read through. Down here, the issue of anti-suicide contracts. I don't know if anybody is actually doing these anymore or not, but please don't. They're really meaningless. The only time they're relevant is if somebody says that they can't contract for their safety. If somebody says, sure, I'll sign on the dotted line, but I won't hurt myself, it's worthless. You've just wasted a sheet of paper. Males are consistently the highest risk. Elderly men, elderly Caucasian men are really the highest risk for suicide. And if you start adding on medical comorbidities, substance use, aloneness, conflict, those raise the risk of suicide. History repeats itself. So if somebody has shown that they have the capability or the ability to attempt suicide once, the likelihood of a subsequent attempt needs to be taken quite seriously. Warning signs, some of these are intuitive and probably you all are quite familiar with, but paying attention to a significant loss, and the death of a spouse is really one of the biggest losses that anybody could experience. If you have a sense that somebody is stockpiling, or if they say they are, if they have access to lethal means, guns, knives, ropes, that kind of thing. I think an important statistic to notice is that up to 75% of older adults had contact with a healthcare provider within a month of their suicide. So, many of the people who die by suicide are not, they're not invisible. They have seen us, and it's important that we, pay attention if somebody is struggling, to be aware of where they might be. Warning signs, if people aren't sleeping, if they're losing weight, a lot of physical complaints, guilty feelings. And there's not, interestingly, there's a fair amount of research in suicide. There's not a lot of research in geriatric suicide or older adult suicide. So this data is actually quite archaic by now, but it's some of the more, I guess, kind of more reasonable research that gives us a little bit of indication. Things that might be protective if people have family, if they have support, if they, kind of have a problem-solving mentality, they're probably going to do better. Religious and cultural beliefs oftentimes are protective. Patients will oftentimes say, I can't because of my kids, I can't because of my dog or my cat. And I think those things are actually relevant. Protective factors, I also am mindful that sometimes even those protective factors are no longer. And so we can't just say, oh, good, they're Christian, or oh, good, they have a cat, so they're not going to kill themselves. I think that also is not true. An interesting aspect of older adults is the notion of dementia and suicide. There's some evidence that advancing dementia might actually be protective. And I think intuitively that kind of makes sense, because suicide is a little bit of an executive function. It takes some planning, it takes some awareness, it takes some access. And the more demented we become, the less of that we have available to us. What there isn't a lot of awareness or research about is mild dementia, mild cognitive impairment, a very recent diagnosis of Alzheimer's disease, and how that might influence someone's will to live. Probably once a month, I'll have one of my younger or milder stage dementia patients ask me about medical assistance in dying and Alzheimer's disease, or sometimes family members will ask me about it because their parent asked about medical assistance in dying. So it's something that is on people's minds. Assessment of suicidality, I'm going to rush through these a little bit because we have lots to talk about otherwise. But again, you'll have my notes. So I will end there. I'm going to stop sharing. And here we are. I hope I wasn't on mute that whole time. What do we do now?
I was going to say, if anybody has any burning questions, please jump in. And then Dr. Kotza and I have a quick case we wanted to share from our local perspective. So ask away.
Yeah, I have a question. Jamie Wilkie, I'm a GP in Fort St. John.
Great.
How do patients in rural communities access ECT?
Oh, that's a tough one. Oh my goodness. I wish I had a good answer for you. We occasionally have had patients come down from Terrace, from the Yukon, and ultimately the patient, we're happy to do it, but either the patient has to have somebody that they can stay with in Vancouver, or they would need to be hospitalized. You know, with COVID, it's really thrown a whole lot off kilter. But yeah, it's a little bit tough.
Yeah, and just kind of a follow-up, just wondering kind of if this was something that was to be attempted to be offered in a rural community.
Yeah.
That's something that there's training available for, and then under the direction of a psychiatrist, that could be something offered in a rural community?
Yeah, so, you know, the standard is that a psychiatrist administers it, that either a nurse anesthetist or an anesthesiologist administers the anesthesia. You know, 50 years ago, actually, when I was a medical student, a psychiatrist that I worked with did it all. Did the anesthesia, did the ambu bag, did the stimulus, did the recovery. I have no idea how they did it, because there are times where things go wrong. And my skill set is not a difficult airway. Yeah, I mean, if you have access to essentially a recovery area in a hospital or an ICU room, and you have an anesthesiologist and you've had training in ECT, all you need is an ECT machine, and you could do it. Do you know, are they doing ECT in Prince George?
Yes, Dr. Marlatt just had made a note that her patient had ECT at UHWBC hospital
Okay.
transfer.
Yeah, so yeah, I think, oh good. So I think, you know, if somebody wanted to start doing ECT in Terrace or Fort St. John or Dawson's Creek or wherever, I mean, there's no reason that they couldn't. And, you know, I always say, if you build it, they will come, which is probably true to some extent. But you also want to make sure that you're doing enough that everybody is maintaining their skill with it. You know, if I'm a general surgeon, well, maybe that's, I was going to say, if I do an appendectomy, you know, once every 10 years, I may not be very good at doing appendectomies. I mean, it's kind of the same thing, that once you do it often, then you kind of keep your skills honed. But there are some courses. Duke University, for example, has a big ECT training course that's hands-on. That would be an option for, you know, for starting that training process. Yeah,
it just looks like mostly the timeline of this kind of sequential week after week therapy is a huge limitation. It's not like sending someone for a surgery and then doing recovery here.
Yep.
Logistics of that are quite complex.
Yeah. Yeah, I think that if there were, you know, some closer in the Northern Health Authority region, you know, aside from Prince George, that were doing ECT, it would be lovely, because the distance is a huge impediment for this.
If I can maybe make a quick comment, Kevin and Jamie, we used to do ECT in Dawson Creek, and I'd say we were doing 1, maybe 2 cases a year And it was actually very difficult to keep one's skills in, and especially when it sort of started going from bilateral to unilateral and whatnot.
Yeah.
I was terrified when I gave ECT, and we're a few psychiatrists. We're not enough where there's people that are always there with their skill set up. If one person goes on leave, half our psychiatrists are on leave.
Yeah.
So if they go on, then we can't do it. And when the credentialing dictionaries came out that required X amount of ECTs per year to keep current, we unfortunately had to throw in the towel. So it's a huge gap in our service. And I mean, I look at it as an essential therapy, and unfortunately, it's been very difficult for us to access ECT. And even when I've tried to sort of motivate it as it's a higher level of care because we don't offer it and someone's actually going to die, we haven't always been able to access services. So it's a worrying thing for me.
Yeah. There's a neurostimulation modality called vagus nerve stimulation that originally was used in epilepsy, treatment refractory epilepsy, but studies showed that it was effective in depression. And I think for many severe treatment refractory patients, it is effective. Lots of debate about that, but the benefit of VNS, vagus nerve stimulation, it's like a pacemaker that connects to the vagus nerve in the left side of the neck, is that it doesn't require anesthesia. Once you have it, you don't have to travel back and forth, and it's essentially something that with a smartphone, physicians can adjust the settings. So it's actually kind of made for remote settings around the world, not just in British Columbia, but it's not. Although it's approved in Canada, it's not approved in BC for the treatment of major depression, unfortunately. So it's not an option.
A couple of questions in the chat. Dr. Marlatt just asks your thoughts on escitalopram dosing, I'm assuming in the older adult population.
Yeah, so I usually will start patients at 2.5 to 5 milligrams and just kind of leave them. I really will move my dosing based on how old someone is, how frail someone is. So if I have a 90-year-old on escitalopram, I may park them at 5 milligrams for a while. Venlafaxine, I've had patients respond to 37.5 and I haven't needed to do anything further. So I really kind of hang out at the low range for a month even before I have a good sense of how somebody is doing. If somebody is, kind of a healthy, vibrant, robust 90-year-old, I may actually treat them more like a 65-year-old. And I'm sure that you all have 65-year-olds that are more like 95-year-olds. So it really just kind of depends on, the overall physiology of somebody. But I would probably start at 2.5 and then move upwards from there. That's my usual practice.
Great. And then just another question from Fred and Dr. Marlatt. Could you comment on quetiapine at bedtime for patients who have ruminating thoughts or insomnia, or in the situation of Lewy body dementia symptoms?
So I am not a fan of quetiapine for sleep. And that goes back to my slide about tardive dyskinesia. I think the risk is too great. If somebody has depression and they're ruminative and they can't sleep, then I think quetiapine is reasonable. Quetiapine is in the CANMAT guidelines for treating major depression. But if somebody is just full of worry and they can't sleep, I would rather Mercazapine, Trazodone, CBT for insomnia. I think there are different approaches. And one of my worries, I guess, or one of my worries is that quetiapine is used for so many different things, and it's not a benign medication. I think we really need to be mindful about it. Quetiapine for Lewy body dementia, I guess it depends on what you're trying to treat. If you're trying to treat hallucinations of Lewy body dementia, that's really a time where I would use a cholinesterase inhibitor, either donepezil, donepezil, rivastigmine, or galantamine. The only time that I would be thinking about using quetiapine would be if the visual hallucinations are causing aggression or significant behavior problems. And then, when it comes to antipsychotics, I think quetiapine is really your only option without risking worsening EPS. The other option would be clozapine, and I don't know anybody who would put somebody on clozapine for this indication.
Great. I'll let anybody else pop on and ask a question, and I'll just get our screen set up.
Yeah, just a quick thing, Dr. Smith. Thank you very much. Lovely talk. I'm Charles Helm from Tumbler Ridge, family doc.
Yeah.
And I just, an observation, as family docs, especially when we inherit patients, we can see people who maybe were given something as a trial, bit of anxiety, query depression, given a trial of an SSRI a long time ago.
Yeah.
We also see quite a few people who are on amitriptyline.
Yeah.
So anyway, so with these sort of people with possibly dubious reasons for going onto these meds, and as you say, some of them absolutely are dependent and that they refuse. They don't touch that. I need that. I can't do without it. And fair enough. We're never going to argue with them. But there are also some others who haven't really had the chance to discuss it, constructively with the healthcare provider, and they just assume I'm on this forever, and they really welcome the chance to talk about it, and some of them really want to stop if they possibly can. So there's a lot of variability there between patients.
For sure. And even the patients who are determined that they're not going to come off of their amitriptyline, there is no harm in ongoing education. And I will always tell patients that this is a medication that if you were to come see me today, we would never, ever, ever put you on it. And a medication that was good for you 50 years ago isn't good for you now. And then I will follow it up and say, there will be a time where I'm going to talk about you where we actually have to get you off the medication. That day may not be today, but there's going to be a time. And then what you've done is you've kind of set that point in time where Dr. Helm says, this is going to be a bad medication for me. And then periodically you just bring it up and say, I wonder if now is a time where we could try at least a little bit less of the medicine and see how it goes. If somebody is on 15 or 25 or whatever milligrams of amitriptyline and they've been on it forever, they're cognitively reasonably intact, they're not so constipated, blah, blah, blah. I mean, if they're really tolerating it, then I tolerate it with them, but we still have the conversation that it's not going to be a good medication the older they get.
And it's also an incredible feeling when you persuade someone to stop and their brain clears and they kind of back to the way they want to be. There are very few things that are quite as fulfilling as that, I find.
I agree, 100%.
Great.
Evan,
Dr.
I have a follow-up question on your experience with stopping people's tricyclics or switching them to other drugs and it not going well. And I can certainly remember a few cases myself. I sometimes suggest to people to kind of go 50-50 and see how things go. So maybe escitalopram is probably one of my drugs of choice. In the elderly as well, that or sertraline. Being right or wrong about that, but
I share that with you, so I think it's right.
So I'll say, well, let's work towards halving your amitriptyline and putting you on maybe a half dose of escitalopram and see how you do. And we can just sit there for a couple of months. There's no rush. You're 70 years old. Do you think that's a reasonable approach before maybe switching?
Yeah, I think that's, and you know, I don't have the chart in front of me with the ones that I did try that. But yeah, I think that's absolutely the right approach. I think that, you know, doing a rapid taper and a rapid titration, I think that is going to do nothing but cause problems. And especially a medication like amitriptyline, if they're on a high enough dose, and if you take them off quickly enough, they can actually get some cholinergic withdrawal. So I think doing a taper like you described it is right. And as you said, generally there's no urgency because they've been on it for 50 years. So hurrying up and getting them off of it probably is not necessary.
Excellent. Lots of great questions and discussions. Dr. Kotze and I are just going to quickly present this case and then talk a little bit about our mental health supports and systems that we have in place here in the South Piece. So this was a patient, MM, a 70-year-old female. She was referred to myself from the hospital staff for frequent falls. She had just fractured her arm, quite confused, and had frequent benzodiazepine use reported by the nurses. She was a very poor historian and unable to accurately report her medications. Just confirming you guys can see the slide. Excellent. So when I saw her, she was very jittery. She had a very noticeable tremor. She reports lots of sedation. She's very nauseous, not able to mobilize well, very forgetful, which she said was new for her, and had ongoing nightmares. She described the anxiety as it felt like if she was having a heart attack. She was crying and uncontrollably shaking. She had just lost a few family members. So back to your points, Dr. Smith, thinking about that grieving versus depression or anxiety. And then states that she uses her stress pills, but they only use when taken at double the prescribed dose. So she wasn't able to help me at all with her medication names. I used Pharmanet to gather this. She was on venlafaxine 300 a day, both lorazepam and temazepam with recent fills, morphine and Tylenol for pain from her recent fracture, metformin for diabetes, and a few agents for nausea. We do acknowledge there are lots of other problems here, but again, we're just going to focus on that psychiatric perspective. So presuming other healthcare providers, myself, just thinking that her anxiety pill was this lorazepam that she was using as needed, but she didn't have her medications with her. She couldn't tell me which one was which. So we opted to show her pictures of the pills. So here we have our lorazepam, venlafaxine, and temazepam. And she was adamant that this pill here on the end was her stress pill that she was taking multiple times a day as needed. And that, for those of you who aren't familiar with working in a pharmacy, is venlafaxine. So for years, she was taking that regularly until about April of last year. Then it started to be filled a few days to a week early. Then she fell over the summer and fractured that arm. And then she was having monthly fills that were being filled every 2 to 3 weeks. And that duration continued to shorten and shorten. And when I had seen her in the fall, she received 5 months worth of medications within 3 months. So we know there's an issue there. So her stress pill is not actually the benzodiazepine that most of us as healthcare providers assumed. And she was on a much higher than recommended venlafaxine dose, which was likely leading to symptoms. So whether that was the excessive dose causing nausea, drowsiness, abnormal dreams, nervousness, movement issues, whether it was her frequent withdrawal because she would take her 600 milligrams, the pharmacy wouldn't fill it earlier, and then she would run out of medication and go through this torture, or was it her serotonin syndrome that with high doses like this and other medications that it was causing some nervousness, insomnia, nausea, tremor, all those types of things. So I don't know that we're ever going to have the answer there, but that's really what led us to do a bit of a cross taper for her. So because she wasn't reliable with her medication histories, we set her up on blister packs and used SwitchRx to help come up with a plan to taper off of venlafaxine. And we chose escitalopram for a lot of the same reasons that you said, Dr. Smith, and why, Dr. Kotze, you prefer that agent. So 3 months later, Dr. Kotze saw the patient. Again, she was still grieving the loss of her family members, but coping quite well. She found the escitalopram to be helpful and denied adverse effects and felt the dosage was adequate and no changes were needed at that point. So overall, a complete and accurate medication review are critical. We never want to assume anything, especially in elderly patients. Being aware of early fills and patients running out of medications should be a clue to do a little bit of a deeper dive, and knowing that the symptoms are often adverse effects of medications. And I know Dr. Kotze wanted to jump in a bit and talk about some of the barriers to optimal patient care that we have in our region. And we also have Fred Smith, who's the Northeast clinical educator for mental health and substance use, with us tonight. So hopefully he can join us and share his perspective.
Yeah, thank you very much, Sydney, for that presentation. So I'm just sort of shooting from the hip somewhat here with my comments, but I remember seeing this patient, and Sydney didn't mention that she's very deaf. So there's a shouting match going on the phone. There are clearly other people in the background, and they commenting on, you know, this, that, and you know, you don't need to speak to the shrink, or you know, and it sounds like a fairly chaotic setup that she's living in. And one of my sort of first thoughts is I'd love to get a social worker in there and an OT, a nurse to sort of do a home visit. She's already fallen and broken her arm. What are the 4 risks? What do her blister packs look like? Is she taking her medication? Is she taking some, not others? Is she, I mean, she's following my golden rule of medication, always double the dose, but she's also double my age. So it's a real mess. And as Sydney said, she couldn't really identify her medication. So now I'm doing a telephone consult. We're trying to figure out, this patient's brand new to me. She can't hear out the things I'm saying to her, and I'm trying to work out what is she actually taking. And I really wasn't sure. And then I phoned the pharmacy where her medication is dispensed afterwards, and they gave me a different story from what she told me, and certainly very different from what the family physician's referral letter said. So there are all these factors, and you are potentially working with someone who is sort of cognitively maybe compromised. So I think there really are just a lot of variables that are not easy to take into account and assess accurately. And I think that's one of the very first hurdles that we come across. I think when people are able to come in person for visits, this is someone that I'd love to see in person with a blister pack. Bring a family member, get the collateral, do a MOCA for at least the baseline, and go from there. And as many advantages as I think telemedicine has had for some people, this is not necessarily one of those population groups. So thank you.
Any thoughts from Fred, or anybody have any other questions for Dr. Smith?
If I can jump in again, Kevin, if you don't mind me asking, this is something that I struggle with a lot, they talk about using lower lithium levels for geriatric patients, and also cutting back on benzos. And I never seem to be able to cut back on benzos, particularly when people have been on them for a long time. And I mean, I try, and it's not for lack of the patient trying. They just don't do well. And we'll try any other anxiolytic, SSRI, SNRI. And I think the main reason why this is really worrying for me are the potential cognitive effects. As someone gets older, I think they have more and more cognitive effects, but the anxiolytic effect, if you take it away, the lack of anxiolytic effect is just as bad for the patient. So, but also cutting back on lithium, and just to your previous comment, do you still keep a therapeutic adult lithium level, but watch it more closely because they may need less?
Yeah, so if somebody is on lithium for a mood disorder, augmenting for major depression, or even if they're stable and they have bipolar disorder, you know, I really kind of target 0.4 to 0.6. Most lab results are, you know, 0.6 to 1.1 or 1.2 or something like that. So we target on the lower range. You know, there's some evidence that higher lithium levels are actually going to be more renal toxic than the lower range. And so, you know, the kidneys are aging and slowing down as it is. And I usually will check, even on people who are quite stable, I still will check a lithium level every 3 months or so. I recently had a patient come to me after things fell apart, but a patient who had been on lithium for, you know, 30 years and hadn't had a lithium level for probably 15 of those. And as she was getting older, diabetic, you can only imagine what's happening with her kidneys. Nobody thought to check a lithium level until she was toxic and then was in the hospital. So yeah, I target 0.4 to 0.6. In terms of the benzodiazepine question, I feel your pain. Like, it's tough. And again, some patients have been on, you know, Valium since the 70s when it was mommy's little helper. And, you know, trying to get them, you know, off is really a challenge. And so it kind of comes back to discussions like we were talking about earlier, of at least, you know, setting the mark of, you know, this is why it's not good for you. Here's what the concerns are: falls, cognition, car accidents, whatever it is. And then, you know, slowly, diligently, at least agreeing in the conversation of trying to lower it. And if you try and it falls apart, well, you tried and you can try again. It's like stopping smoking, right? Just because it failed once, maybe eventually it will stick. It also kind of depends on how much of a benzodiazepine somebody is on. You know, I'm treating somebody who actually, when he first came to me for treating his GAD, generalized anxiety disorder, he was on 3 different benzodiazepines, clonazepam, lorazepam, and temazepam. And our first goal was just to get him onto one, right? It made no sense to be on 2 different benzodiazepines, including the case that was just presented to be on temazepam and lorazepam. Doesn't make any sense. And then we've gradually worked down from his daily dose of 8 milligrams of lorazepam, which was the equivalent of what he was receiving. We've gradually been working down over the course of a couple of years, and he's still on 5 milligrams, but at least it's not 8. So it's, you know, we're trying to make some inroads, but yeah, there are some patients that are always going to be on benzodiazepines. That is just how it is. So.
Great, thank you. And I see Fred's popped on his video now too, so if he's available to share some words.
Hi. Yeah, my name's Fred Smith. I'm not related to Dr. Smith, but you never know.
You could be.
We look alike. Anyway, I just want to introduce myself as the mental health and substance use clinical educator for the Northeast. Part of my role is to support staff and managers in regards to providing services in our mental health programs. We're unique in Dawson Creek. That's where I'm situated. That we have the psych unit in the on the same parking lot. So when people are discharged, there's a good integrated system and seamless program, which is nice because we all know each other. And part of the discharge process is to have the clinicians be part of the discharge while the patient's on the psych unit. So that's unique in itself. We've used a primary care model approach, which basically means that we're an interprofessional team consisting of nurses that are public health, long-term care, rapid mobilization, and mental health and addictions. Our mental health and addiction staff are mainly probably 50% nurses, a few social workers, and other allied professionals. The one thing I really encourage people to do, especially with, as our talk is elderly, that when somebody presents with a primary issue of depression, a lot of secondary issues might be contributing to that depression. So it could be, they could be misusing prescription drugs. They could be having some pain. They could be having, they might have a terminal illness. They may have past trauma. So I really encourage in my education role clinicians look at the big picture, the holistic picture. And some are trained holistically, others are a bit more siloed in their experience and their training, but that comes with education. And Dr. Kotza, the psychiatrist, meet with us once a week and meet with all the clinicians, and we talk about the patients. So basically people are hearing about the medical side, hearing about the psychological side and the housing needs and all the other things. I find people that come in that are elderly are quite unique, and you might have about 3 or 4 people involved with that person's care. My wife, who's outside with her dog right now, is the diabetes health unit, and she often sees people with maybe a primary diagnosis of diabetes, but secondary depression and anxiety disorders that come along with that. So we're all trying to work as a big happy team. I cover from basically Tumber Ridge, Chetwynd up to Fort Nelson. Some communities are very resource strapped, so we do the best we can, and others have the luxury of having a bit more of a wholesome team to work with. But we're lucky that some of us have worked together for almost all of our career, and it's nice to have those the consistency and the collaborative work. So when I first started here, we just had a 12-bed psych unit with a few community nurses. So now we're quite expansive, and we also deal with ICMT, which is intensive case management, which looks after homeless people. Again, sometimes we're dealing with elderly folks out in the community that are homeless with the opiate crisis. So we got a lot of programming around that. The opiate crisis doesn't have an age limit, basically, and we're definitely a lot of resources and programming's been put into that sort of care. Is there any questions? Or?
Fred, just to take you up on one of your comments there about the secondary causes and so on, and this will date me as to when I did my training, but when I trained as a medical student, we were taught the 2 main categories were endogenous depression and reactive depression. And those categories have sort of gone, you don't hear it much anymore, they've gone out of vogue. But I think the point that you've made, Fred, and that Dr. Smith made, because Blanche to me is endogenous. Yeah. She's not reacting to anything major going on in her life. And these are the people I've always liked that definition, and I've kept it with me, those 2 categories in my approach, because I found it very useful. And the endogenous ones, I think, tend to respond better to the medications. And with the reactives, let's work out what's going on and try and treat the cause, rather than just treat the depression. So I've always found that useful. I don't know, Dr. Smith or Fred, what you think of that.
Well, yeah, I used to use that term a lot, like exogenous and endogenous. And I think, sometimes people get put on an antidepressant, as Dr. Smith was referring to earlier, and they come see us, whether it's a loss and I can think of my own mom who, when she went through a loss, she went through a severe depression. The doctor put her on an antidepressant, but really she needed, some CBT, grief counseling, and other, supports. And we kind of see this quite a bit. And I would say, honestly, over 50% of our clients, maybe 70% are situational things going on, or some, maybe loss or secondary medical things going on. And so we have to look at CBT, and we do programming in our communities, but again, we don't necessarily always have the experienced people to do the ongoing groups and the amount of CBT that's required. So it is, kind of a different mindset. Sometimes we have to look again at the big picture. What are all the other factors contributing to that depression? Like you said,
I think the notion of endogenous and reactive, I think that it gives us a little bit of a way to approach someone who's presenting with us. I don't know Blanche's younger years. My guess, though, is that her very first episode was reactive. and then family history, or just that's how her brain is wired, ultimately it was no longer reactive. The episodes just happened. And that's oftentimes the case. Equally, there are some people who have a reactive depression. I'm reminded of a patient that I saw 6 weeks ago or so, whose dog was stolen. She crashed her car and there was a flood in the apartment above her. And she was reactive, right? But along with that reactiveness was incessant tearfulness. She wasn't eating. She was having some vague suicidal thoughts. And the only reason she wasn't kind of acting more on those was because of the hope that she would find her dog. So she had a lot of neurovegetative symptoms of depression, even though you could say it's because of this, this, and this. And she actually got an antidepressant because she was so paralyzed by her symptoms. She met the diagnostic criteria for a major depressive disorder that not giving her kind of a pharmacologic part of her treatment, I think would have not served her well. And so, you know, I think that there are times where people who have a reactive component really still warrant medications. And there are other times, though, where I think maybe they would not. So, but I think the premise of you know, kind of how you might conceptualize someone's depression fits into the biopsychosocial model of psychiatric illness.
I just had a quick question. If the person's grieving loss to the point where their vegetative symptoms are quite pronounced, and they're in bed all the time, generally, what do you see as far as recovery when they can actually come off that antidepressant?
Well, if they've never been depressed before, if they've never had a major depressive episode and they've suffered a loss, whatever it is, and they need an antidepressant, you know, I would say, and they get better with it and they're doing fine on it. My approach with them would be to say, let's see how you look at a year's time. And at a year's time, if you're doing well, then let's look at tapering and withdrawing the medication. And I wish I had a percentage, either my own experience or research, that would say how successful that can be. But there's a large percentage of people at all age groups who have a single episode and they will never ever have an episode again. But if you've had 3 or more episodes in your lifetime, the likelihood of having a 4th and a 5th and a 6th is essentially 100%. So if it's 1 episode, you're going to fit into the 30% risk of recurrence. If you've had more than 2, or if you've had 2, it's about 60%, and beyond there, it's roughly 100%. So the odds are in their favor that they'll be able to come off of it if they've only had that 1 episode.
If I could maybe just sort of add on to what's already been said, I think the importance with reactive and endogenous is essentially, if it's reactive, you've got to very directly address the reactive part of what's going on. I always remind myself about, you know, what is the definition of psychiatric illness in the first place? And it's if your symptoms are causing significant impairment or distress. And so not everyone who has something bad happen in their life goes on to an antidepressant. But if you are having significant impairment on whatever level, interpersonal relationships, occupational, and so on and so forth, or distress where you cannot cope with your symptoms, then you've got to look at treatment. And again, I think most studies will show that the people with the best outcomes use a combination of pharmacotherapy and psychotherapy. So it's not, you shouldn't be choosing between one or the other. I think it's both. And I often say to people, if your brain, we use some medication to get your brain a little better, your neurochemistry a little better, and then you're going to work better with psychotherapy, grief counseling, whatever the case may be. I won't give everyone who's going through grief an antidepressant, that's for sure, but optimizing someone's functioning and then psychotherapy seems to, you know, be more effective and they remember things better. So that's sort of how I look at things.
Yeah, I think that's right. I always tell people that psychiatric illness is when there's impairment in work, love, or play. And that's kind of how we base when somebody should be treated. I don't know if any of you are tennis players, but if you look at Rafa Nadal, who just has all of these quirky, compulsive, and kind of rules about how he plays tennis, you would look at him and say, my God, he's got obsessive compulsive disorder. But just on the surface, he probably does not, because he's entirely functional in his work. Now, who knows about his love and his play, but at least on the surface, he's not impaired, even though he really looks like he would be. So yeah, I fully agree with that, with what you just said.
I don't know if there are any other questions, but I'm going to kind of grab the the role of just doing the thanks. And Kevin, first and foremost to yourself, thank you so much for coming and speaking with us from the big lights. And yeah, it was very informative. I'll tell you, my pearl that I'm taking away is the tearfulness that comes with delirium. I've never sort of heard that or picked up on it, but I'm certainly going to look out for it in future. So thank you very, very much. And also to Sydney for your presentation. That was great and also sort of really added value, I think. And then everyone who helped put this together, thanks to all of you as well.
Thanks very much for the invitation to present. I'm happy to have been a part of this.